Great. Well, good morning. I want to thank everyone for coming, especially the first one up, rolling out of bed after last night. And thank you to the organizers for inviting me to share what our center has been working on, because I'm really excited about what we've been doing. So today I'm going to talk about one test fits all and the implementation of clinical HiFi sequencing for a pediatric rare disease. All right, so I expect most people in this audience are aware that rare disease is actually not rare at all. And so it affects about 300 million globally, depending on what day you Google that, and that equates to about 1 in 10 people. So that means several of us in this room are impacted by rare disease outside of our profession, right? It's an important problem. And in 2024, a publication in The Lancet stated that the average time to diagnosis is still 4.8 years, and that 30% of children with a rare disease unfortunately still pass away before the age of 5. So we have a significant need for diagnostics in rare disease. Multiple studies have demonstrated that the addition of short-read genome sequencing after exome sequencing or other standard of care testing is really only incrementally increasing our diagnostic yield from 8 to 10%. And that's actually pretty consistent in the literature across studies. Alternatively, it's also been proposed that 85% of diagnoses could be captured by short-read genome sequencing, but that still means that we're missing 15% of those diagnoses if you were to take a short-read genome approach first, and that also isn't really moving that diagnostic needle as much as we would like it to. So on top of that, one of the most exciting things of being in rare disease and being in genetics for as long as I have is that we've seen this exponential growth and novel gene discovery and gene disease association. So that's been tremendous for our patients. And if you follow OMIM, you'll see every week and every day almost there's a new association published. At the same time, we've had an increasing recognition of the complexity of rare disease and how complex our human genomes are. Not that we didn't know that, but to see that in practice and diagnostics, I think really is important. And so where we started with our single nucleotide variants, which has really been the bread and butter of a next generation sequencing, in particular short-read sequencing, we also have to recognize that we have copy number variants, so hence the invention of arrays that we've used for so long. But we have an increased recognition of expansion disorders, so well beyond Fragile X or Huntington's, which are kind of the classic examples when we're learning anyway. We have methylation disorders, again, our classic imprinting disorders that we're looking at. We have this complex structural variation, as you saw last night in that patient from the UDN. And then not to be forgotten is the mitochondrial genome, which we also need to assess when we're looking at patients with rare disease and not forget about that important part. So then the challenge of genetic testing, even if you adopt a short-read genome strategy first, is which test are you going to order if you don't have a comprehensive one-test-fits-all approach. And if it turns out, if your center is like ours at all, most of our patients have forgotten to read the book on their disorder and show up with all the features that you would expect. And so which test first? So then the result is, and again, in the absence of this single test, is that we have the lab is maintaining multiple assays, and clinicians are faced with deciding which test do I want first. So in some institutions, you might be fortunate to have laboratory genetic counselors that will help you with that lab utilization, but most of us aren't. There aren't enough genetic counselors to help with all the test orders. And so here I've listed kind of the 5 common ones that labs are maintaining. And ultimately, maintaining 5 separate tests clinically is expensive. So the more testing assays you have, the more time it takes and the more money it takes. So selfishly, from the laboratory perspective, that means that we have to maintain the reagents, we have to maintain the proficiencies, and we have to keep all of those running 5 separate times. That's an expense for us. It's also expensive for the payer, right, because they're going to end up paying for multiple tests. And because we do try to be good stewards, all of us do, we're not going to order these tests concurrently, except for in the most extreme cases. So you're going to have sequential testing. And so again, here's kind of standard turnaround times of depending where you start. You might do a test, it'll take a month, go back to pre-auth, see if you can do another test. That takes who knows how long, come back, and then wait another 4 to 10 weeks. It just depends. And that's how we get very quickly to that 4.8 average for a diagnosis. Alternatively, if you had a comprehensive approach where you did one test first that got most of your diagnoses, then you could shorten that. It would be easier for the clinician and easier for the laboratory and ultimately easier for the payer, right? Just check one single box, and that's our goal. And so I just think I learned by examples. So a real common example in our institution of how this matters or the impact it can have is we look at the hypotonia challenge. And so congenital hypotonia affects about 0.8 in 1,000 births. So we'll just say 1 in 1,000 births. That's really common presentation. And it turns out that congenital hypotonia actually has complex mechanisms for the cause. And the top 3 differentials, being a repeat expansion, methylation disorder, are complicated by a pseudogene, are not readily detected by short-read sequencing. And we looked back over a 5-year period. This has been published. It's a few years old now. We should probably revisit it. But we have about 100 patients a year at Children's Mercy that are coded with a congenital hypotonia or diagnosis of that. And 35% of our patients did not receive any genetic testing, so there's opportunity for improvement there. And then when we looked at the ones that did receive testing, about 54% received a diagnosis. And it's actually really important because precision therapeutics, particularly in this arena, are rapidly being developed. So if we think about spinal muscular atrophy, those treatments have been transformative and curative, so much so that that's been added to newborn screening. So what's the financial impact, though, of having a complex disorder that's relatively common that requires multiple approaches? And so we do have a hypotonia panel, many institutions do, where we look at those top 3 differentials and just those 3 loci. And that's a single test the clinician can order, and it's a cost of about $2,000 with a turnaround time of 3 weeks. And so we looked at then our last 50 cases of those to see what we were doing or how we were doing with that hypotonia panel. Only 10% were diagnosed with that panel, so we start there because it makes sense, but we only have a 10% diagnostic rate. 41 patients went on to receive additional testing, which was comprised of microarray or exome sequencing. Overall, we got to a diagnostic rate of 39%, which is pretty good. It tracks with where we are in rare disease in general, but the cost for just these 51 patients was over $400,000 in testing. And I didn't pull the time, but it was significantly longer than 21 weeks. So again, we have a lot of room to improve for us and our patients. So we're very fortunate at our institution to have a program called Genomic Answers for Kids, which is a pediatric repository where we're enrolling patients and families with rare disease so that we can begin to understand diagnostics in rare disease. And this program is really built on sharing. So on the research side, please reach out to us if you're interested. And under that umbrella, we've sequenced over 2,000 HiFi genomes. Again, these are primarily trios, and they're all children with rare disease and their families, and sometimes affected siblings. And so when we looked at our research cohort, because our research and clinical, we do both, most of us, we saw that we had equivalent or superior single nucleotide and copy number variant detection, in addition to getting expansion and methylation disorders. And so indeed, as we've previously shown, this is from our research studies, we've seen, again, that we do really well with our sensitivity and specificity on single nucleotide variant detection. Our long-read genomes do better than short-read genomes, but we should all remember that we're doing really well with short-read genomes. We're all probably pretty happy with those numbers. We can see that we do better with our structural variant detection, so we have an increased number or detection of structural variants and copy number variants. And in particular, we see inversions that we don't see at all with short-read sequencing. And then again, of course, as we all know in here, we get methylation, which is important, as I've said. And so building on that experience, then our research experience and how excited we were, and I can tell you in the research cohort, we get about a 10% bump in our diagnostics. We decided to move and validate that workflow clinically so that we could offer it to our clinical patients, which is important as a test. It's also not everybody has access to research. And so we really felt strongly about offering this as a clinical test. And so we did, as our validation of the workflow, we took 18 samples and ran them on the Revio. So all of our clinical work has been on the Revio instrumentation for comparison to our historical data. And we also were able to get through some of the 6 choreo controls. You have to work a bit. Sometimes that DNA is challenging. Our sample types include cultured cells, so amniocytes, and other cells, and primarily we are getting blood samples from our patients. We also have subsequently added on different tissue types and bone marrow. We do hold it pretty stringent, so our proband samples are sequenced to a target of greater than 90 gigabases of data, so we want to make sure that we have 30x coverage. And then down below, you can just see the different types of samples and things that we tested of known disorders to make sure we could recapitulate them from expansions, copy number, structural variant, et cetera. This is not for memorization, but just in case you have questions. So when we move into a clinical workflow, we aren't able to immediately adopt the latest and greatest pipelines, which can sometimes be really disappointing, but we have to go through that extra step. So this is just to show that we're using, we use the PacBio Widow pipeline. We're in Azure at our institution, in case there's anyone else who might be in that environment. We do run the target, but we've clinically limited that currently to 52 disease loci, so we wanted them to have relevance in pediatrics, and also make sure we had a strong disease gene association so that if we saw something, we could report it back. Of course, we have direct methylation, and we've limited that to 11 loci currently. And then paraphase, which is what is looking at those complex or pseudogene regions, we've limited that currently to 11 loci. The catalog has expanded on the research side. So how did our validation, so when we locked everything down and we decided to move forward, how did that look in our hands for us? So our comparison to the genome and the bottle data revealed that our sensitivity of HiFi, again, is still running slightly higher than our short read, which is exciting and it's what we anticipated, but you can see, again, we're doing really well on both sides. Specificity for HiFi was 99.95%, so we're doing fantastic there. I think what was also really reassuring for us is that our precision has been over 99% when we compared different library preps and different sequencing runs. So we're seeing the same results across multiple samples. Copy numbers are a little bit harder. We don't have that same kind of true set from genome in a bottle that we do, or not the same catalog for SNVs, so we are relatively strict. But on average, we recapitulate greater than 90% of our copy number variants. And again, that's due to the fuzziness sometimes of how copy numbers are called. If the end ends in a seg-dup or an LCR, the overlap can vary a little bit. And then importantly, our expansion testing has revealed 100% concordance between HiFi target and orthogonal methods. And these were the loci that we tested in our validation, but we've had that 100% concordance throughout running our samples. And again, our complex loci by paraphy recapitulated 6 out of 6 known variants. I think what is interesting is that for the factor 8, we had put that sample in. It had sequencing, I think, in the early 2000s. It was a send-out test. And it was reported back that the family had an inversion in factor 8, which leads to severe factor 8 deficiency or hemophilia. And it turns out they actually don't have an inversion. They have a deletion of factor 8. So it didn't change the overall diagnosis, but we did get the correct molecular mechanism, which was pretty exciting to see. And then for methylation, we do struggle with just one particular loci clinically, IC1, which is for isolated Beckwith-Wiedemann syndrome. That's due to the reference of G38 that we're using right now. So there is a patch, there is a way for you to incorporate that, but it's not easy for us to do. So right now, that's one limitation we have in our methylation. So what are the couple unexpected findings that have really, I think, highlight the importance of long-read first approach? So the first case was a proband that was 9 months old that had a history of abnormal muscle tone, microcephaly, and global delays and seizures with vision anomalies. Mother had had multiple miscarriages or reported them, and so the differentials from the clinical team were tuberous sclerosis, so TSC1 and 2, and COL4A1 when they were trying to put the phenotype together. And in fact, what we found is that they have a large expansion in a gene DIP2B. And that's just showing you on the very far right, you can see the difference from the reference allele. And so the patient, again, has a maternally inherited full expansion. So one allele had an expansion of 7 and the other 857. The mom was very similar in her expansion of 12 and 837. And so we could quite clearly see this, and there's no question that this repeat is real. We didn't have questions about that. But what we could also see is that the proband's allele was hypermethylated. And so here you can see the allele on top where you can see that increase in methylation. And this is associated with a disease presentation. So it's known in this gene, you should have the pathologic range is over 350 repeats, and that individuals that are exhibiting symptoms have a hypermethylated allele. The mom who had a different phenotype actually did not have hypermethylation. Again, this has been documented in other case reports. So we explained the difference in phenotype, we explained the child's features and the inheritance for this family. I think what's important is that this gene likely would have never been on the differential, or it would have been many years before this gene had been on the differential. It's not commonly on TP-PCR panels for expansions that you could order clinically, and you'd still have to think about this gene to ask for it. And the methylation also gave us that additional functional insight, because otherwise we have 2 large repeats and people with very disparate phenotypes, and it's not a very common disease. We've probably ascertained because, again, it's not easy to test for, but still it gave us more confidence seeing that difference in methylation. So the second case I have quickly to show you is that this was a patient that was referred for sequencing at, again, about 1 month of age, for a history of hearing loss, some gray matter heterotopia, and microcephaly, so multiple findings. And the family reported a history of some distant relative that had a deletion on 18p and maybe a duplication on 6p. So we knew to suspect a chromosome disorder from the phenotype and from the family's reported history. Most people don't Google. That's pretty specific. But no one had ever followed up in the family to do any parental chromosome analysis to see what might be happening for them and help define their recurrence risk. And so, of course, maybe not surprising at all, we see indeed that this patient in front of us has a deletion on 6p and a duplication on 18p. So we have a structural variant of the same chromosomes. And if you're wondering, I'm not sure if maybe they flipped it in the other case or if we have a different segregation within the family. But what is helpful for our clinicians and our families is that we can see clearly on the top, the proband has that gain, so that's where we're seeing the duplication, but we're seeing and confirming down to the base pair that the father is a balanced translocation carrier. So it took 1 test for us to get the diagnosis, tell the family who the carrier was, and help the genetic counseling. So not only 1 test fits all, but 1 genetic counseling session fits all, and that's helpful too. So if HiFi had been run first in our clinical experience, what is the difference between that? So in our standard of care testing, we got the diagnosis right in 16% of cases. And if we ordered the right test the first time we got a diagnosis, then that turnaround time was equivalent. Well, that makes sense because our short read exome and genome sequencing that's expedited has the same turnaround time. But I think we should note, so why aren't we running long read on everyone? Is that long read is still more expensive than our short read or standard of care testing, and the throughput still doesn't quite match short read sequencing. We do want to point out that the current HiFi analysis is really just our diagnostic floor. So we know there are additional information that we can leverage from the genome we're working on our research side, and then we hope to move that into the clinical side. So we think that diagnostic rate is only going to go higher. So hopefully I've showed you or convinced you that if your HiFi is done first clinically, that we can lead to an increased diagnostic yield and a decreased time to diagnosis. That HiFi testing first allows for a reduction in the number of tests, so simplifies our algorithms, and that continued studies will help delineate the right patients for a HiFi-first approach until we can get to the spot where everybody just gets a long-read genome. And so this is our research institute and our clinical building where we are, and I'd just like to acknowledge all of our collaborators and our team that works on this, and especially Genomic Answers for Kids. And I think I have time for at least 1 question this morning.